discuss the latest developments in the clinical practice related to the hypertension management and to look into the controversies and the consensus in the management of the hypertension in the day-to-day practice. Totally in the talk, basically to see what is the treatment scenario for hypertension in India and history of blood pressure measurements and the role of ambulatory blood pressure monitoring. The role of ambulatory blood pressure monitoring is increasing day by day because of the lot of lacunae in the measurement of the clinical office blood pressures. There are a lot of lacunae in the measurement of office blood pressures, hypertension, and to see the aspects of managing hypertension in diabetic patients and CKD patients. So, coming to the hypertension in the Indian scenario, as you all know, hypertension is a very common disorder, increasing day by day. The prevalence is increasing day by day, especially in the urban population and also in the rural population. But when we see the trends in the last 50 years, there is a significant increase in especially in the urban population, and we can see these figures. This is the situation even in developed countries also. Majority of the hypertensives are not detected. Many patients, nearly 41% in the urban population and 25% in the rural populations, they are not aware that they are having hypertension. It is only detected when they seek doctor attention for some other problem. And you can see the hypertension, only 37% of the population for hypertension are being treated, and to a strange surprise, only 20% of the population, hypertensive population, the urban population, and only 10% of the hypertensive population, the rural side, are adequately treated. Our common practice is they take a pill and they forget about it. They presume that they are being treated, but they are not treated to the level that is needed. So, despite of all the efforts, the level of awareness among the BP is still low in India, and lot of efforts needs to be kept with the physicians to treat the patients to the optimal level. When we just go into the history of blood pressure measurements, initially it was the first idea of checking blood pressure was done by Stephen Hales, and he did an invasive animal based study to assess blood pressures, and later mercury manometer, again the invasive measure was method, and later the Ramaraju was the first to identify and develop a mercury based sphygmomanometer, which is now being still used nowadays. And the blood pressure measurements is the most important event required in the clinical practice, but most of the times every one of us will give a least importance to the blood pressure measurements. This is how the giant in hypertension management, Dr. Kaplan, this is the statement what he has given. The measurement of the blood pressure in the clinical is the clinical procedure of greatest importance, but is performed in the most slopiest manner. We give very least importance to the technique of blood pressure measurement. To say what is the ideal way of measuring the blood pressure? At least average of the 3 recordings should be taken, and at least in the first setting, and each to be taken at least 2 to 3 minutes apart, and the patient should be refrain from smoking or consuming tea or coffee at least 30 minutes before taking measurements, and we should make the patient sit comfortably for at least 5 minutes in the quiet room before taking a blood pressure measurements. And both blood pressure can be taken as in supine as well as standing position, supine or sitting position, but ideally when we keep the arm should be at the heart level. And measurements, especially both arms should be taken at least in the first visit, and at least in the supine and standing position in all the diabetic patients to rule out any autonomic neuropathy. So these are the techniques which make the blood pressure vary. So if you don't make the patient rest for more than 5 minutes, if the patient is not seated properly, or if correct size is not used properly, and deflation also, the rate of the deflation of the sphygmomanometer should be 2 millimeters per second. That should be the rate of deflation. But most of the times we will be in a hurry and we will be deflating at a very rapid rate. So we will be underestimating or overestimating the exact blood pressure. So ideally 3 readings should be taken. Suppose the first one is the highest, we should take the average of the rest of the 2 readings, and that is taken as the ideal blood pressure. But whatever the things we suggest, what are the recommendations, but 99.9% our office blood pressures are not done properly, either because we are too busy, or our staff which record the blood pressure, they are not trained properly, or too busy, or the environment where we record blood pressure too crowding. The person who is recording the blood pressure may not record properly, or may not listen properly to the cough sounds. So in order to overcome these problems, the recent trend is to adapt ambulatory blood pressure monitoring, because taking blood pressure recordings out of the hospital environment, out of the clinic environment, gives actually the exact measurements of blood pressure in clinical practice. So ideally the ambulatory blood okay. So ambulatory blood pressure monitoring gives an important information regarding the real life blood pressure in various settings, when the patient is at rest, or when the patient is sleeping, etc. And it gives a more correlation for the end organ damage compared to office blood pressure. And especially it is more useful to identify nocturnal blood pressure, which is more important, especially in a diabetic patients or in elderly patients where there is an autonomic neuropathy. The nocturnal fall in the blood pressure which we expect during night time will not be there. So we cannot record the nocturnal dipping pattern in a routine office based blood pressure. So ambulatory blood pressure gives a more important information regarding the nocturnal blood pressure patterns, because the patients who are non-dippers, that is those patients who doesn't show a fall in the blood pressure during the night time, are the patients who are likely to develop strokes in the near future. So identifying non-dippers is identified only by adopting ambulatory blood pressure monitoring. So these are some of the indications where we recommend ambulatory blood pressure monitoring. So all borderline hypertensive patients, or to rule out white coat effect, isolated systolic hypertension, to detect nocturnal blood pressure, resistant hypertension. Many of the times you will be giving 3 or 4 drugs, blood pressure will not come down, and you will be forced to add one more drug. Suppose in such patients, suppose if you are giving more than 2 drugs, it's always ideal to prescribe to recommend for an ambulatory blood pressure, because most of the times the patients, once you come to the clinic, the white coat effect will be there to some extent. So even if you are giving 2 or 3 drugs, once your patient comes to the clinic, you will be recording again high blood pressures. So instead of giving a third drug, always ask for an ambulatory blood pressure monitoring, because most of the times they will be having normal blood pressures once they are out of the clinic. So these are the basic European Society of recommendations. Optimal level of nocturnal blood pressure should be less than 115 by 165. So what are the limitations? Ambulatory blood pressure, basically it causes some inconvenience to the patient, because every time the patient will be will be doing the work at least for 24 hours with the cuff, and it will be recording every 20 minutes whatever the person is doing, and during night it will be recording every 20 minutes or 30 minutes. So it causes some discomfort during the 24 hours, except that it gives an accurate measurements. So what do the guidelines say, and what are the similarities and differences? We have 3 groups of JNC 8, ESH guidelines and ASH guidelines, and recent recommendations of these 3 landmark guidelines say that the threshold for drug treatment should be more than 140 by 90 in those patients less than 60 years, and more than 150/90 in those patients more than 60 years. And coming to the drug therapy, earlier the beta blocker used to be the first line management in many of the recommendations, and of late JNC 8 and ASH, they say that beta blockers cannot be considered as the first line management. And similarly, when do we initiate at least with 2 drugs? If the first blood pressure measurements is systolic more than 160 or diastolic more than 100, there is no point in prescribing a single drug. So if the blood pressure recording is more than 160 systolic or 100 diastolic, straight away you can go for a combination therapy. So these are some of the Indian recommendations in the Indian guidelines. Indian guidelines recommend, especially in the younger patients, either AC inhibitors or ARBs or beta blockers. And in the older patients, about any older patients more than 60, you can start with diuretics or a calcium channel blockers. In the step 2, if it is not controlled, you can add any drug from the other group. So new beta blockers are given importance in the Indian guidelines. New vasodilating beta blockers like latest generation beta blockers like nebivolol or carvedilol, they are giving more importance rather than conventional old time beta blockers like selective beta blockers like atenolol. And there is also important emphasis going on. Stress is to use the polypills, especially in the long-term therapy. The using polypills increases the patient compliance, and though we can give fixed drug combinations, we can use 2 or 3 drug combinations so that the patient will be taking only single pill, which really improves the compliance of the patient. And also in treating the patients, you should consider associated risk factors like dyslipidemia, obesity, insulin resistance, etc. In treating these patients. So Indian guidelines still recommend beta blockers as agents to be used in the first line younger hypertensive patients, and chlorothalidone is now available and it's shown to be better than hydrochlorothiazide in many of the trials, because especially it's a long acting one and you can use as a single day OD preparations. The earlier we used to think the beta blockers are the only molecule because they used to have a cardioprotective effect. So the cardioprotective effect of beta blockers off late has been questioned, especially in the 2 landmark trials where one of the important thing is life study, where the angiotensin receptor blocker losartan has found a more cardioprotective efficacy, and it has shown to reduce all-cause mortality compared to atenolol. And also in the ASCOT study, the calcium channel based amlodipine based preparations have shown more protective effect compared to atenolol. So now the emphasis is more on the usage of newer beta blockers, especially the beta blockers with the vasodilating effects. So in the recent 2006 Heart Asia journal study published in Heart Asia journal, they showed that there is an importance of beta blockers, especially third generation vasodilating beta blockers like nebivolol, to be included as a first line molecules whenever you are choosing beta blockers. So what are the recent trials and what are the practical? These are the 2 trials, SPRINT and HOPE-3. They were published in the Lancet and NEJM last year. And the idea of the SPRINT trial is basically to study what is the optimal level of management of the hypertension. Should we use a conservative management, or we strictly reduce the blood pressure to 120? They selected especially non-diabetic patients, and they studied the 2 groups. One is intensive management and as well as the standard management. In the intensive management, they tried to reduce the blood pressure to systolic around 120, and in the conservative management, they used to standard group, they used to manage with a systolic blood pressure of 140. So to the surprise, they have shown that this study was stopped prematurely, because in those subset of patients where blood pressure was reduced in the intensive group, where the blood pressure was reduced and maintained around 120, there was a significant reduction in the composite outcome. In the intensive treatment arm, there is a 25% lower risk of primary outcome. Primary outcome is cardiovascular mortality and the incidence of non-fatal myocardial infarctions, etc. So this study was terminated prematurely, showing that in those patients where there is an intensive blood pressure reduction, there is a significant mortality benefit. But here, when can we take these trial results into the practical world, in the day-to-day treatment, can we apply them? It is very, very difficult, because they gave maximum importance to optimal blood pressure recordings. Optimal blood pressure recordings was the main stress given by this. I can say practically no one will in the routine practice will give such an importance for the ideal blood pressure measurements. So what they did is, in each patients, the patients were allowed to seated in a quiet area for 5 minutes. Then the BP was recorded without the clinician available in the room to reduce the white coat effect. At least 3 recordings were taken, and the average of the 3 were considered as an optimal management. So if proper BP measurements were not recorded, and if we try to reduce the blood pressure to less than 20 in our routine practice, we try to over-treat the patients and we try to create more adverse effects. So if you are taking this trial results into consideration, we should always see that the blood pressure is recorded in a proper way and maintained in a proper way. So what is the formulary this trial used? It has used chlorthalidone instead of hydrochlorothiazide, and amlodipine was the calcium channel CCB of choice, and it has shown that beta blockers are less effective in preventing CVD events as a primary treatment of hypertension compared to amlodipine. And another landmark trial is HOPE-3 BP trial. This is a sub-study from the HOPE trial. The main hypothesis in this trial is, in those patients who were labeled as moderate risk for cardiovascular disease, they tried whether intensive reduction of the blood pressure even less than normal by using hydrochlorothiazide or candesartan, will it help in reducing the cardiovascular events. In a normotensive patients, especially in the diabetic patients, reducing the blood pressure to maintaining around less than 120, will it help in preventing cardiovascular events. But it has shown that reducing the blood pressure with an intensive treatment will not help, and it will not reduce the cardiovascular events. No significant difference in individual components of the outcome, total mortality and new onset of diabetes in patients who were subjected to intensive treatment. But even in this trial, subgroup analysis has shown that in those patients where the blood pressure is more than 150, the treatment with candesartan and hydrochlorothiazide reduced the cardiovascular event rates. Again, this trial also gave a lot of emphasis on the blood pressure management protocol. So what authors from the HOPE-3 say that they contradicted the lower the better hypothesis, and they say that the data are compatible with the hypothesis that treating patients without cardiovascular disease who have a systolic blood pressure above 140 appears to be beneficial, but if the patient has blood pressure between 120 to 140, you need not treat with a high intensive approach, because maintaining the blood pressure around 120 to 140 is ideal, and any treatment that is aiming to reduce the blood pressure further less than 120, though it showed a benefit in the SPRINT trial, but the SPRINT trial has given a lot of importance on the ideal way of blood pressure measurement, which we cannot really do. So in the routine day-to-day practice, if you can maintain the blood pressure, systolic blood pressure between 120 and 140, it will be ideal. So especially the importance is in the subset of patients with hypertension, with the diabetes and CKD. This is one of the landmark trial, ACCORD trial, which utilized beta blockers, calcium channel blockers. And this ACCORD trial, there is a lot of similarity between ACCORD trial and SPRINT trial. Both of them subjected the patients for intensive management as well as standard treatment. And in the ACCORD trial, it showed that there is no difference in the intensive and standard treatment compared to the primary outcomes. So in type 2 diabetes, targeting a systolic blood pressure less than 120 as compared to less than 140 did not reduce the rate of composite outcome and primary event rates. So what is the goal of the BP to be taken? So all of the trials have shown now less than 140 by 90 is the ideal, and less than 150 by 90 is the ideal for the patients more than 60 years. But only thing is, if the patient has proteinuria and the patient has CKD with proteinuria, we should see that the systolic blood pressure is maintained less than 130. This is the only indication where the blood pressure needs to be treated aggressively and the systolic blood pressure has to be maintained less than 130. So when to give antihypertensive medications? standard treatment, standard recommendations as of now is whether to give early morning blood pressure, because to reduce, because the patients will be having early morning surge, whether to give an early morning pill or a late night pill. So still we don't have any adequate data to say what is the ideal time to give an antihypertensive medications. So as of now, the recommendations say that all the antihypertensive treatment should be given early in the morning, except in the diabetics, where additional dose needs to be given late in the evening also, to reduce the nocturnal rise in the blood pressures. So subjecting these patients to ambulatory blood pressure is one of the way, where suppose if you see even night blood pressures are higher, it's ideal to give one more additional dose in the nights to reduce the nocturnal non-dipping pattern. So these are the some of the trials where the results are not come. The MAPEC trial and time and HYSIA trials. So these are some of the ongoing trials where they're studying exclusively on the timing of the antihypertensive drugs, and where they will be give maximum benefit to the patient. So to conclude my talk, the hypertension remains a condition of public health importance in India, and we should improve the methodology to record the accurate blood pressure, and the recording the accurate measurement of blood pressure recording should be given utmost importance. Ambulatory blood pressure is a useful tool in, especially in certain subsets of patients, and though recent trials say lower blood pressure is more important, but we cannot really apply in the real clinical scenarios. And ideally, if we can maintain between 140 to 120 to 140 systolic blood pressure, that will be ideal, except in those patients where the patients have CKD and proteinuria. And BP goals can be lowered further in some special populations like CKD. And choice is totally individualized. It all depends upon the associated factors, and choices have really there is no ideal beta blocker antihypertensive as such. It is basically the clinician choice, until unless there are compelling reasons to choose a molecule.